It's my pleasure to present our poster on outcomes of type 2 diabetes clustering replicated in the DEVOTE and the LEADER trials. I do need to point out that Anna Kokoska, an MD PhD student at the University of North Carolina, is really the person who drove this analysis, but unfortunately couldn't be here. And Kaja Kvist at Novo Nordisk is really the bronze in the operation who conducted most of the analyses. What we tried to do was to replicate the findings of the ANDIS study involving new onset patients with type 2 diabetes new onset patients with diabetes in Sweden. They grouped patients based on 6 demographic and clinical variables into 5 clusters. Cluster 1 was really more or less type 1 diabetes, and then 4 type 2 diabetes related clusters. So we tried to map their clustering to the DEVOTE trial and the LEADER trial, and then examine outcomes. In DEVOTE and LEADER, the population was very high risk for cardiovascular disease, average durations in the high teens of diabetes. The population had a duration of about 15 to 20 years. We were able to calculate the age at diagnosis by knowing the duration of diabetes and their age, but we only had 3 of the clustering variables that the ANDIS cohort used: BMI, age at diagnosis, and hemoglobin A1C. And then we tried to replicate the clusters by using the exact cluster centers reported in the ANDIS trial, and then calculating the minimum distance of individual patients to that cluster center. If you look at figure 1, it's not unexpected that the distribution of hemoglobin A1C, BMI, and age at diagnosis in the different clusters was similar to that which was seen in the ANDIS trial, because we did try and replicate it. But it is nice to see that, in fact, it turned out that way. You can see that in both DEVOTE, where the intervention was insulin, and LEADER, where the intervention was liraglutide or a placebo, in both trials on the background of usual care, that these clusters are heterogeneous with regards to hemoglobin A1C, BMI, and age at diagnosis. More interesting, though, is in figure 2, if you look at the mean hemoglobin A1C and BMI over time, on the left hemoglobin A1C, on the right BMI, you can see that the patients that started with the highest hemoglobin A1Cs had the greatest drop in hemoglobin A1C, and by definition those were the SIDD-like patients, but that the difference with higher A1C persists even with intervention. The higher BMI persists even with intervention, including interventions that are associated with changes in BMI, liraglutide, and insulin. And then most interesting, if you look at figure 3, it's the time to the first of various events. So in panels A, it's the time to the first severe hypoglycemic event. In panel B, the time to the first MACE event. C is time to see cardiovascular death, and D, time to all-cause mortality. And the interesting bit is in both trials, it seemed like the MOD-like group, the moderate obesity group, I think is the abbreviation, those are the patients that had the highest risk of severe hypoglycemia, statistically significant in the DEVOTE trial where there were more events because it was an insulin trial, but the same pattern is replicated in the LEADER trial below. In both DEVOTE and LEADER, time to first MACE was statistically significantly greater in the SIDD group. Now that stands for severe insulin deficient diabetes group, but I do need to point out, as came up in the question and answer session, that we don't actually know that these patients are insulin deficient. We've just mapped them to the ANDIS terminology. But what we see is in both DEVOTE and LEADER, that SIDD-like group had the highest risk for MACE. If you look in C and D, other cardiovascular outcomes, the same pattern is maintained, though only statistically significant in the LEADER trial for time to cardiovascular death and time to all-cause mortality. So I think the important points are, first, that we're able to basically replicate the ANDA study to cluster patients in a geographically heterogeneous population with a much longer duration of diabetes and at high cardiovascular risk, that these clusters are robust to intervention with insulin in the DEVOTE trial and with liraglutide or placebo and usual care in the LEADER trial, and that these clusters are associated with differential risk of outcomes, severe hypoglycemia and cardiovascular endpoints. I'm not sure that this clustering is particularly relevant to clinical care at this point, but it suggests a method that could inform precision medicine in the future. So we will do further studies to try and identify clusters, even using on-treatment effects in future analytic efforts with an aim of developing markers for patients who are at higher risk of bad outcomes and for whom interventions are associated with specific benefits. Thank you very much.